Hello everyone, I'm Dr. Mariam. Today we are going to discuss the topic malaria. Moving on to what is malaria and what causes malaria. So, what is malaria? It is a serious disease that spreads when the patient got or the individual is got bitten by a mosquito infected by Plasmodium parasites. When it bites, the mosquito injects malaria parasites into the bloodstream. It is caused by a parasite called Plasmodium, which is transmitted via the bites of infected mosquitoes. And in the human body, the parasites multiply in the liver and then infect red blood cells. There are 4 species of Plasmodium were known to cause malaria in human, that is P. falciparum, P. vivax, and P. malaria, and P. ovale. That is the Plasmodium falciparum, Plasmodium vivax, Plasmodium malariae, and Plasmodium ovale. So these are the 4 species of Plasmodium which is known to cause the malaria in human beings. Moving on to the epidemiology. So it is mostly seen in the season in July, between July and November, that is usually in the monsoon season. The definitive host is Anopheles mosquito and the intermediate host here is human, and it is rarely transfusion related. It is mostly commonly it is due to the mosquito bite and due to the Anopheles mosquito, and rarely it is a transfusion related. And when talking about the incubation period, the 4 species, as I've mentioned in the previous slide, the P in if it is caused due to the Plasmodium vivax, the incubation period will be 8 to 7 days, that is between 14 days. If it is caused due to falciparum, it is 12 days, 9 to 14 days. Malaria in 18 to 40 days, that is 28 days, and P. ovale, that the incubation period will be 16 to 18 days, that is the 17 days usually. So these are the incubation period of the Plasmodium, which is causing the virus malaria in the human beings. Next is the pathophysiology. So how it is caused and how the person gets infected. So when the infected mosquito bite a human being, this parasite starts reproducing in the liver, and some parasites remaining dormant for years before becoming activated. So in the bloodstream, further, this will get reproduction occurs within the RBC, and the parasite reproduction results in further RBC infection. The cycles of RBC infection and destruction coincide with fever and chills, and the dormant versions of the parasites are ingested by another parasite. So this is how the physiology, what is happening in the human beings, and how this infection or this infected mosquitoes bite is, how it develops in the bloodstream, and what are the things are happening inside our body. And in rare cases, there are malaria which can pass from a pregnant woman to the fetus during the pregnancy or birth, and it is possible but unlikely for malaria to be passed through a blood transfusion or organ donations and needles, through the surgical needles or syringes, etc. So this is the pathophysiology of malaria. Moving on to the clinical features. Symptoms can be mild or severe. As malaria gets worse, it can cause anemia and jaundice, that is the yellowing of your skin and the whitish paleness on the eyes. So this can happen. This symptoms can be mild or severe. And when do symptoms begin if the patient is getting infected with malaria? So malaria symptoms usually appear a week to a month after the person got infected, and some people don't feel sick for a year or longer after the mosquito bite. So sometimes even after the treatment, malaria infections can get better but come back, or means reoccur again. So the patient can start having symptoms again years after the initial infection. And we can divide these into few, like a prodromal symptoms: cold stage, hot stage, sweating, etc. So under prodromal symptoms, we can see headache, photophobia, muscle ache and pain, anorexia and vomiting can be seen. And in the cold stage, what And in the cold stage, what happens here is sudden shaking, chills, or rigor, pale and cyanotic, 10 to 15 minutes. And in the hot stage, the person will get flushed, agitated, restlessness, oriented, and delirious. Severe frontal headache, pain in the limbs and back, and it can happen to in between 2 to 4 hours. And sweating, profuse sweating, and weakness and exhausted can be seen, and for several hours can be seen in the patient. And while talking about the risk factors, though the patient, the possibility of getting malaria, the risk of getting malaria is very higher if the patient live in or travel to the areas where it spreads more. So the patients are at higher risk of serious illness and death if the patient is younger than 5 years old, or pregnant, or have a weakened immune system, don't have access to healthcare. So these are the few risk factors you have to keep in mind while diagnosing or while seeing the condition like a malaria. Differential diagnosis. So we can see in case of malaria, the differential diagnosis are dengue fever, leptospirosis, typhoid fever, scrub, typhus, and severe bacterial sepsis. So these are the differential diagnosis of malaria. And in condition where the malaria is very complicated or severe, we can see these warning signs like confusion, drowsiness, severe weakness or continuous high grade fever, hyperparasitemia, impaired consciousness, hypoglycemia, multiple seizures, respiratory distress, pulmonary edema, hypoxia can be seen, jaundice, hemoglobinuria or red or black urine, and abnormal bleeding, severe anemia, circulatory collapse. So these are the warning signs in cases of severe complicated malaria. Next is the diagnosis of malaria. So first, initially while diagnosing, you have to do the clinical diagnosis, for examine for the fever or unexplained systemic illness, history of ask for the history, medical history, general, like family history and all, and ask them the history of their travel from endemic area with previous year, and ask them to think about malaria until proven otherwise. And so ask about their travel history, medical history, and general health history, and medications history too. Next is blood film. So it can, this blood film, it can take any time or at the height of the fever for three consecutive days. Gimsa stain thick film and thin film are used. So this thin film and thick film. So thick film for MP positive or not, and thick film facilitates the diagnosis of the low level parasitemia. When coming to the thin film, it is essential to confirm the diagnosis, to identify the species of parasite, and to quantify the parasite load by counting the percentage of infected RBC. So this is the thick film and thin film thing you can do for the diagnosis of malaria. Moving on to the rapid diagnosis test, that is the RDT by ICT. So rapid diagnosis is done for falciparum, that is the Plasmodium falciparum parasite. So parasite F test based upon HRP2, that is the histidine rich protein 2, is done, and the rapid diagnosis for falciparum and vivax, that is the Plasmodium falciparum and vivax, we can do LDH coated optimal test kits are present, which the test will take only 5 minutes, and the sensitivity will be 100%, specificity will be 96%, and so this is the importance of rapid diagnosis test. And we can differentiate as we can differentiate using, actually mainly we are doing this rapid test diagnosis test for the in case of falciparum, that is I have mentioned that Plasmodium falciparum. So this will help us to do the rapid diagnosis and also help us to differentiate this falciparum and Plasmodium vivax also. It is suitable for microscopists less experience in examining blood films and can detect up to 14 days. And so these are the importance of the ICTs as a rapid diagnosis test, that is the RDT. Moving on to the management. So here in management we'll see individually how to manage the vivax malaria, falciparum malaria and all. So individually we'll see how it is. So anti-malarial medications can treat malaria and clear the infection from the body, but it's very important to start treatment as soon as possible. So if malaria is not treated properly, it can cause serious health problems including permanent organ damage and death. So the first thing is we'll move on to the vivax malaria. So plasmodium vivax malaria is like a benign or and it only causes fever with chills. It responds quickly to the chloroquine, and there is no chloroquine resistance, but it has a hepatic dormant stage, so which is not affected by chloroquine. So after a few days it reoccurs. So hence for a complete cure, tissue schizontricide, that is the primaquine, should be given. And coming to the medications we can prescribe is tab resorcin 300 mg 4 stat after food, then 2 tabs after 6 hours, then 2 tabs daily for 2 days, that is chloroquine, and to be given with antacids and antiemetics, that is MSids or perinorm. Then you can advise prescribe tab primaquine 7.5 mg 1 bd for 14 days. If oral treatment is not tolerated, you can advise injection resorcin 5 ml IM for 6 hourly for 7 doses. So total doses of 25 mg per kg you can give. And in severe cases, injection resorcin 15 ml in normal saline slow IV over 8 hours, then 20 ml resorcin slow IV for next 20 hours. So this is how you can treat the vivax malaria and the medications you can prescribe to treat the vivax malaria. Next is the falciparum malaria. So this is a dangerous form of malaria affecting different organs, mainly the brain, causing cerebral malaria which can be fatal. The second problem, which is of recent origin, is of chloroquine resistance necessitating the use of other drugs. And the standard treatment you can give in this condition is you can prescribe tab resorcin 300 mg 4 star after food and antacids, then 2 tabs after 6 hours, then 2 tabs daily for 2 days. So this is how you can do. And the next you can advise tab amlar 3 tabs stat, it is a single dose. So this you can advise. And if the falciparum malaria is chloroquine resistant, you can, that is, for example, if fever does not reduce within 2 to 3 days of above treatment, or if the area is endemic for chloroquine resistant malaria, then add 2 of the following drugs, that is tab falcigo 50 mg 2 bd for 1 day and then 1 OD for 4 days, or you can advise capsule larithar 40 mg 1 bd for 1 day and then 1 OD for 4 days. This is the one thing you can do. Second, you can advise tab cunarsol 300 mg 2 tabs for thrice a day and for 7 days. Third, you can give tab amlar 3 tabs stat single dose. And the fourth, you can advise capsule doxy 100 mg 2 times per day for 7 days. So this is you can do in the falciparum malaria condition. Next is the like anti-malarial drugs. So anti-malarial drugs, next is the anti-malarial drugs. So anti-malarial drugs, here you can advise injection quinine 300 mg per ml for into 4 ml in 5% dextrose drip for slow IV over 4 hours and then 8 hourly. And you can also advise injection Falsigo for 2 vials IM or IV stat, then 60 mg IM or IV per IM IV after 6 hours, then 60 mg IM IV daily for 4 days, or injection Palutar 80 mg IM 12 hourly for 3 days, or injection Mostar 150 mg IM OD for 3 days. So this is the anti-malaria drugs you can advise or prescribe. And there are other treatments you can do in the ICU. That is, you can advise prescribe injection mannitol 100 ml IV 8 hourly to reduce cerebral edema. And if deeply unconscious, nursing care, RT aspiration, ET and mechanical ventilation, SOS. And if high fever, you can advise fapanyl infusion 1000 mg in 100 ml IV. Cold sponging also can be done. If convulsions, you can advise injection Calmpose 2 cc IV stat and SOS, and ventilator with muscle relaxant if repeated convulsions are present. In case of hypoglycemia, injection 25% glucose 50 ml stat and 10% dextrose drip. And in case of tachypnea, pneumonia or ARDS, which I guess I have not mentioned here, you can note it down. If tachypnea, pneumonia or ARDS present, you can advise mechanical ventilation with PEEP, meropenem 1 gram IV for 8 hourly. That is, it is a higher antibiotic. And you can also advise efcorlin, Lasix and derifilin. So this you can advise in cases, so if there is tachypnea, pneumonia or ARDS. If acidosis, injection soda bicarb up to 50 ml IV. Then dialysis if acute renal failure is present, and exchange transfusion if parasitemia is greater than 30%, anemia, acidosis is present, then you can do exchange transfusion. So these are the treatments you can do in the ICU. These are the treatments you can do in the ICU section. Next is the prophylaxis of travelers to endemic areas. So these are the things which I'm going to do explain is for travelers in endemic area. It is not recommended for residents of the endemic areas. For all type of malaria, tab risocin 300 mg once every week, continued for 8 weeks after leaving the endemic area. Tab primaquine 7.5 mg BD for 14 days in last 2 weeks of chloroquine prophylaxis. This is for all types of malaria. For falciparum malaria, you can advise tab laverin 100 mg 1 tab daily from 1 week before travel to 4 weeks after leaving the endemic area, or tab mefloquine 250 mg into 1 tab every week for from 1 week prior to 2 weeks after. So if stay is prolonged after 1 month, you can prescribe half tab every week. So this is what you have to do for the travelers who are present in the endemic area, but should not recommend to the residents of the endemic area. Moving on to the monitoring and follow-up. So what are the things you have to do to monitor the patient who is diagnosed with the condition of malaria? That is, first one is you can do is blood smear should be repeated twice daily in severe infection within 48 to 72 hours after start of treatment. Patients usually become febrile and improve clinically, expectant complicated case. All patients should be investigated with repeated blood film of malarial parasite 1 month upon recovery of malarial infection to ensure to recrudescence. So this is what you have to do, and the monitoring and the follow-up you have to do to the patient who is diagnosed with the condition like malaria. This one topic is very important, that is pregnancy and malaria. So in cases of malaria and pregnancy, at the time of pregnancy it is 10 times higher risk. And first trimester you can advise quinine or mefloquine with clindamycin for 7 days. In second and third trimester, you can advise quinine or mefloquine plus clindamycin for 7 days. Artemether plus lumefantrine can be used. Primaquine and tetracycline never to use, and frequent investigations and monitoring are strictly required in case of pregnancy and malaria. So pregnancy, you have to keep note, it is very risk, 100 times risk. So make sure when you come up with a patient, or you diagnose a condition in pregnancy cases. When you see pregnancy cases, make sure you follow up these points. And about the severe and complicated malaria, that is an medical emergency. The patient should be referred to a tertiary care, and treatment should start urgently, and patient needs multiple investigations, fluid and electrolytes correction should be done. So this is have to be done in the case of severe and complicated malaria. And how we can prevent this malaria? So if the patient is traveling to an area where malaria is very common, then I ask or advise them to talk to the doctor or the practitioner about the ways which we can prevent being affected. And you, as a practitioner, as a doctor, you also have to advise the patient to get what are the things they can do to get getting prevented from getting infection from the malaria. And the medications can greatly reduce the chance of getting malaria, but if the patient gets sick with malaria while on an anti-malarial drug, it won't work to treat it. So we have to take precaution. We have to advise them to take precautions to avoid mosquito bites, to lower the chances of getting malaria. Then you have to advise them apply mosquito repellent with DEET to exposed skin, drape mosquito netting over beds, put screens on windows and doors, and treat clothing, mosquito nets, tents, sleeping bag, and other fabrics with an insect repellent called permethrin. And I can also advise them to wear long pants and long sleeves to cover the skin. So these are the ways with which we can prevent from getting infected with malaria. And you can also advise the patient who got affected also, or who is diagnosed with the malaria also. You ask them to do these preventive methods so that they will not get infected again. So this is the topic about malaria. This comes to the end of our topic. Thank you.